Hi everybody, my name is Kristi. I'm one of the first years if you don't know me, and today I'm going to be presenting on my clinical part. All right, so I'm going to start with a case. So you have this 53-year-old, startlingly young-looking female coming in. She has no past medical history, but she's coming in with worsening dyspnea exertion and a little bit of hemoptysis for a day. She notices that she has had worsening lower extremity edema for the last month. She denies any medications or allergies. On your exam, she's afebrile. Blood pressure is a little on the high side, not too bad. Her heart rate is pretty high though. She's tachy in 120s. Respiratory rate is okay, but she's satting 94% on 2 liters. You notice that she's a little bit anxious. She's a little bit dyspneic. On your lung exam, you note that she has bilateral basal crackles and she has some lower extremity edema. Again, EKG, she's tachycardic and she might have something going on. So she's in sinus tach. There's a little bit of left atrial enlargement, a little bit of LVH, and then on your chest x-ray, you note that she has increased interstitial markings. So just some possible differential diagnoses: tachycardia, a little bit of hypoxia, PE. Okay, yeah, PE. So in this case, this is a real case from a patient, not here, but basically they get a CTA PE to rule out PE. Okay, so after the PE, she comes back, she gets worse. She has like worsening dyspnea, she becomes diaphoretic, she becomes really agitated. Repeat vitals show she's still afebrile, her heart rate's gone up, her blood pressure is through the roof, over 200s, over 100. Respiratory rate has gone up, and she's now setting 90% on 100% non-breather. Oh no, what did you do? All right, so suddenly she goes into asystole. Do some quality chest compression, then she gets ROSC. So as this is going on, you're running the code and all the labs are being drawn and they finally come back. This is what you find. So her TSH is very low, almost undetectable. Her free T3 is 20, quite high. And she also has an elevated free T4. So what is this case? It's contrast iodine-induced thyroid storm. Very rare, but this is a real case that happened in Japan. So my case, my clinical pearl is going to be on thyroid storm. What is it? How do you diagnose it? How do you treat it? Okay, so first a little bit of endocrine basics. So you have your hypothalamus, it secretes thyroid-releasing hormone, that's in the anterior pituitary, and then you get TSH. So you're going to be measuring the TSH and T4 and T3 levels in the blood. TSH works on the thyroid and basically secretes T4 and T3. It's going to secrete 80% T4 and then 20% T3, and T3 is actually the active metabolite. T4 is converted into T3 in the peripheral system, and then that's the main hormone that acts on all the organs. In the left lower corner, I'm going to talk a little bit about the Wolff-Chaikoff effect, but basically you need iodine to make thyroid hormones. So this is a little counterintuitive, but you have a low iodine state, it's actually going to upregulate the production of thyroid hormone. And if you have a very high iodine state, you're going to go to something called the Wolff-Chaikoff effect. Basically, your thyroid gets overwhelmed with all the iodine, and you're going to decrease your production of thyroid hormone. And then just basic review, I'm sure most of you know this, but elevated TSH and low T4, that's hypothyroidism, and then low TSH, high T4 is hyperthyroidism. All right, so hyperthyroidism and thyrotoxicosis are basically the same thing per se if you have an excessive amount of thyroid hormone in the body, but thyroid storm is an extreme manifestation of this, and it's basically a clinical diagnosis. It's an acute, severe, life-threatening hypermetabolic state. You're basically going into adrenergic overdrive, and the mortality for thyroid storm is actually 8 to 25%. So you want to look at a few systems to diagnose thyroid storm: circulatory, thermoregulatory, fever. I have altered mental status from their CNS toxicity, and then GI. The classic triad in thyroid storm that I have on the board is hyperthermia. Usually it's 40 degrees Celsius or more. You have tachycardia, and you have altered mental status. Some other things you can see: you can find patients in CHF. They might have a wide pulse pressure, and they might be jaundiced. Okay, so how do we diagnose it? So if we're not all astute clinical monsters, which we are, but if you haven't had years, down the road where you're able to look at a patient and be like, oh, this patient's in thyroid storm, maybe they're just tachycardic, or maybe they have a PE, then you can use something called the Birch and Ortowski diagnostic criteria. And this is basically going to tell you what the chances of them having a thyroid storm are. So basically, if you take out MD Calc, which I'm going to ask my juniors to do now, we can go back to the case, and if you look up Birch-Schwartzowski diagnostic criteria, we look at a few things: temperature, CNS effects, GI involvement, heart rate, congestive heart failure, is AFib present, and then precipitating event. So I'm going to go back to the case in the beginning. Basically see. Okay, so for this lady, all right, her temperature, she's afebrile. Okay. CNS system, she has a little bit of mild agitation. I'm going to give her a test +10 for that. GI, hepatic dysfunction. All right, so if anybody gets a number, feel free to call it out.
30. I got 30.
Yeah. So I got, what did I get? I got
40.
I got 35. Well, I guess I kind of, so around there. But either way, 35.
They're all bad.
Yeah, they're all bad. So suggestive of impending thyroid storm, basically. And then you gave her the CTA-PE, and then I'm going to go over some of the triggers later. But basically, the iodine contrast just pushed her over into thyroid storm.
I feel like the CHF thing is tricky, right? Because she did have signs of pulmonary edema, but was she in severe CHF exacerbation? Like, that's sort of weird.
Yeah, so, I mean, it's like a clinical diagnosis. Like, some people might get a different score, but that's why there's a range. So the range, let's see, going back. So 25 to 44 is basically impending thyroid storm, and then less than 25 is unlikely. And if you get over 45, that's a high likelihood of thyroid storm. So this tool is not necessarily very specific, but it's pretty sensitive. And then if you just clinically suspect thyroid storm, you want to treat them before waiting for the lab results, except for a pregnancy test. So orders, what are you going to order? And what should you expect? First, get a pregnancy test. Get that urine and run it to the POC lab, because this is going to dictate what kind of medications you give them for a thyroid storm. And then your basic lab, CBC, you might see leukocytosis with the left shift. CMP, you want to check the renal, hepatic functions, identifying comorbidities. Glucose, they have hyperglycemia, or they have hypoglycemia. Cortisol, this is oftentimes found to be high. If it's low, you might want to consider concurrent adrenal insufficiency. You want to get a chest x-ray to just rule out infection as a trigger. If they're coming in totally altered and you don't know what's going on with them, that's a good idea. Consider a CT head if, again, they're altered, you don't know what's going on. This is just part of your AMS workup. And then EKG, which oftentimes shows sinus tach. In 10 to 35% of patients, it can actually show AFib. All right, so here is an overview of all the different treatments that you're going to be giving your patient and the different systems that you're going to be treating. So supportive care, if they have a fever, beta blockers are the second, and that's going to decrease their adrenergic drive. Steps 3, 4, and 5 are basically all going to work on the thyroid, and then step 6 is going to prevent thyroid hormone reabsorption and GI tract, and then number 7 will treat the trigger. All right, so number 1, supportive care. Okay, IVO2 monitor. Oftentimes they'll have a fever. If they do, you want to treat them with ice packs or a cooling blanket. And if you're going to give an antipyretic, give Tylenol, not aspirin, because aspirins actually can increase the free thyroid hormone. And then IV fluids, usually a good idea. Check the sugar. If they're hypoglycemic, you can give them D5. And then step 2. So step 2 is going to be your beta blockers. So you want to inhibit the peripheral adrenergic effects. Your first line is going to be propranolol. This can be given IV, or for less sick patients, you can give PO. If they have asthma or some sort of other reactive airway disease, you can use cardioselective agents such as atenolol, metoprolol, calcium channel blockers. Some other people might prefer an esmol drip. It's more easy to turn on, turn off, titratable. And if beta blockers are contraindicated, these are some other drugs to keep in mind: reserpine and glufenidine. And then the 2 bottom drugs, reserpine and glufenidine, you want to avoid in both CHF or cardiac shock. And remember, a lot of thyroid storm patients can present with CHF. Okay, steps 3 and 4 are basically going to work on the thyroid. So I apologize, I know you guys kind of got on your biochemistry cap earlier in the day, but there's just going to be a little bit more for you guys. So step 3, you want to inhibit the T3 and T4 synthesis. And 2 of the drugs that we're going to use are methanazole and PTU, propylthiouracil. Both can be given PO. They basically prevent the synthesis on a molecular level by preventing the coupling binding of iodine. So it's kind of hard to see this graph here, but basically you have iodine floating in the peripheral blood. It gets taken up by a thyroid cell, and then in the thyroid cell, one iodine molecule gets basically joined with another iodine molecule and then it goes through this organification process where you get T3 and T4. And methimazole and PTU basically kind of block off this process of the iodine coupling. There are a couple differences in the two drugs. So PTU, the pro of it is that it works peripherally, not just in the thyroid hormone, but also works in the peripheral system to prevent the conversion of T4 to T3. But the con is that it has higher rates of liver hepatic failure, basically, and this can sometimes even result in death in certain cases. Methimazole has a longer half-life, there's less dosing, there's no hepatic failure risk, but for this reason, you're usually going to use methimazole for most of your patients. The con is that it's teratogenic, especially in the first trimester of pregnancy. So this is why you want to get your point of care pregnancy tests first thing, so you can determine if they're pregnant and then try to figure out what trimester they're in if they are. Sometimes it's kind of hard to remember this, but the way I remember it is MMI, methimazole, 2 M's, you're in the second and above trimester, PTU, pregnant first trimester. I know this might not work for everybody, but that's how I remember it. So everybody gets MMI except for if you're pregnant in the first trimester. So you want to wait about an hour before you give the next drug, which is going to be potassium iodide or another iodine-containing agent. Okay, so step 4. So you're going to inhibit the release of T3 and T4, and this you're basically going to use the Wolff-Chaikoff effect that I talked about earlier. You can give potassium iodide. Some other agents you can use are iodine lugol or graphene lithium carbonate. And you want to give the iodide 1 hour after the administration of the cyanamide, basically to prevent this iodide from being taken up as a substrate and creating more thyroid hormone, which is not what you want. So basically, again, the high iodide bolus is basically going to decrease the release of thyroid hormone through the Wolff-Chaikoff effect. And the way this works is basically there are these potassium iodine symporters, and they basically block that symporter from being used when you give high doses, and it also decreases the thyroglobulin synthesis, which is the carrier molecule in the blood. Obviously, don't give it to patients with iodine allergies, iodine overload, iodine-induced hyperthyroidism, like in the contrast case, or amiodarone-induced hyperthyroidism. Okay, steps 5 and 6. So you want to block the peripheral conversion of T4 to T3. And the way you're going to do this is by giving a steroid. Glucocorticoids, 2 options are hydrocortisone and dexamethasone. So propylthiouracil and propranolol also block a little bit of conversion of T4 to T3. T3 is the active metabolite again, but not to as great of an extent. So give steroids. And then if they have coexisting adrenal insufficiency, you're also treating that. So step 6 is you're going to prevent the reabsorption of the thyroid hormone with cholestyramine. So this is a bile acid sequestrant. Basically, thyroid hormone is metabolized in the liver and then secreted as bile into the GI tract. Cholestyramine will bind to that bile, basically you'll be able to flush it out. Okay, and then just identifying what exactly triggered their thyroid storm. Some of the big things to think about are infection. If they have some underlying infection going on, check their body, get that chest x-ray if they're upset and maybe get a urine. DKA can also trigger you into thyroid storm, having an MI, an iodine low, like in our case, hypoglycemia, hyperglycemia, a PE or pregnancy, like molar pregnancies, and also having recently delivered can also trigger a thyroid storm. And then thyroid medication overdose. Are they somebody who accidentally took too much of their Synthroid? Okay, so in summary, I know that's a lot, but basically from 1 to 7, supportive care, IV fluids, maybe antipyretic, cooling blanket if they need it, beta blockers to block the adrenergic surge, decrease the heart rate with propranolol, and then methimazole versus PTU. Remember PTU used in the first trimester, potassium iodide, work on that Wolff-Chaikoff effect, decrease the thyroid hormone synthesis, steroids to prevent the peripheral conversion, and cholestyramine to flush it out of your GI tract and then treat the trigger. Most likely these patients are going to end up going to the ICU. All right, so in summary, thyroid storm is a clinical diagnosis. use the Birch and Retoxy score to help. Remember, this is sensitive but not necessarily specific. Get a pregnancy test before you start treating. Remember, PTU for pregnancy in the first trimester, otherwise everybody else gets methimazole. Propranolol with corticoids and treat the underlying trigger. And then these are just some celebrities that have hyperthyroidism / Graves' disease: Missy Elliott, Wendy Williams, and Thea. Okay, these are my references. And these are my more important references. Thank you to everybody who helped me with this presentation: Drs. Eli, Keith, Ray, and Dr. Nyla Devato. Thank you.
That's a really good review of thyroid storm. It's really important to realize that thyroid storm is a clinical diagnosis. The Birch-Retoxy score is going to tell you chances that this patient might have thyroid storm. And it's really important to tell the difference between thyroid storm and thyroid toxicosis. You're not going to give all those medications to every single patient who comes in tachycardic and has a low-grade temp who's got hyperthyroid. Sometimes those patients really just need beta blockers and methimazole. And it's really important to differentiate, even if not every single thyroid storm patient necessarily needs the steroids. Those are going to be like the severe, really sick thyroid side patients that you're really going to get any benefit out of steroids. We're just going to throw everything at them. Most of them, the most important thing we do for them is the beta blockers, because the biggest risk for them in that moment is going into high output failure and things that kind of go along with that. So bringing the heart rate down is going to be one of the most important things you're going to do. And that's going to be the most important thing, is giving them the right amount of beta blockers. And don't be afraid to put them on an esmolol drip. And we like the propranolol because it prevents that conversion of T4 to T3. And I think because of the PTUs of prevention of T4 to T3, even though it has a worse side effect profile, for the really sick thyroid storm patients, you might consider doing PTU instead of the methimazole, just because you get that added benefit. And I think that's the important thing to remember. But it's usually going to just be beta blockers, methimazole, and the iodine. Just remember to wait on the iodine, or else you're just feeding a hungry thyroid.